Much to share anyway.
Okay, sir.
चलो ठीक है जी. Assalamu alaikum, everybody. I can't see who's online.
Sir, just a second, please.
नहीं, अच्छे बहुत सारे लोग हैं.
Yes, sir. Actually, there are people from different parts of the world. There are people
Okay.
from some people from African countries also.
Yeah.
There are some people
Okay.
from Gulf countries, some people back in Pakistan, some from India.
Oh, very good, very
So we
good.
have a mixed
Medium of
English.
expression will be English.
Yes.
Very good. Yeah, I struggle with English, but I hope we'll be able to do something. Okay, great. Thank you very much, guys. I know some of you are on mute and some of you have got your cameras off. I would like it to be a little interactive session, more like a question and answer session than a didactic one-way trying to transfer information. So I think I've got no agenda. I've given a broad topic of regional anesthesia. That is something I do a lot, something very close to my heart. I do limb blocks, trunk blocks, all kinds of blocks, you name it, kind of blocks, mostly acute pain, not chronic pain, because chronic pain is not my specialty. So I am open to taking questions, and as we go along, I'll try to answer them as best as we can. And if anybody else in the group have got expertise and experience on a particular area we're trying to answer, please chip in, share what you know, and we'll have a discussion around it. So,
is the voice of Dr. Kamran is not clear? I think it is clear. I can hear it clearly. So check the connection back from your side, Dr. Sadaf.
okay, so I can see there are 48 people online. Anybody can start with a question. Just make sure you unmute, you put your video on so we can see who's asking the question, and then we'll get the discussion going.
Assalamu alaikum, sir.
Assalamu alaikum.
Sir, I am Dr. Asam, consultant anesthetist in King Salman Medical City, Medina.
Mashallah, very good.
I just want to ask the role of erector spinae block for post-operative pain in patient with lap coli.
Okay, that is a very good question. Now, before we go into detail of it, I would like to ask people in the group, and I know it's very difficult because there's so many people there. Is everybody aware of erector spinae blocks? So how would I know if people are? So I would say if you've not done any or you're not aware of what it is, please say either in the text or speak up.
No, and I would very much like you to explain the procedure.
Okay, who's that? Sorry.
I'm Nadeem from Lahore.
Nadeem from Lahore. Okay, very good. Okay, now basically, I think when we are talking about different blocks, and when we are talking about newer blocks, especially, which we have not done in the past or which are coming up more recently, I find YouTube very helpful. So I go on YouTube, I read up the anatomy before I go on YouTube, I see a number of videos, and then get a better idea of how the block works, what is the best way of doing it, where it works, and then we start to do it in my clinical practice. So erector spinae blocks is one of them. When I was training, this block does not exist. It is a relatively new block, and apparently it works very well. Now, any one of you, have you seen any YouTube videos on this, or have you performed the block yourself?
I have performed block myself, ultrasound guided.
Ultrasound guided, exactly. You have done it yourself. And anybody else in the group who's done these blocks? No? Yes. Kumari says yes. Okay. Right. So I will go into a little bit detail of this. So basically, erector spiny block is kind of a thoracic paravertebral block. And it is done right. So this is, somebody is sharing this paper. Is this on erector spiny blocks? Yeah, okay. Yeah, thank you very much. So this is similar in terms of coverage to a thoracic paravertebral block. I have used it a number of times for rib fractures, and I have used it for open cholecystectomy procedures. I have once or twice used it for lap choles where the patient is on a shed load of chronic pain medications and where we anticipate that the pain control post-operative will be difficult. So answering to the question, original question, yes, it works magic. It works very well. I would say, now this is my experience and feel free to disagree with it. I would say that if thoracic paravertebral block is going to take all your pain away, erector spiny block will reduce it by about 80%. So if the morphine requirement post something is going to be 10 milligram, with the erector spiny block, you can bring it down to 1 to 2 milligrams. So that is how effective it is in my experience. Do you people in the group who've done that, do you share this experience or do you have a different experience from this one?
I have the same experience. The erector spiny block is a magic in post-operative management.
Exactly. And in terms of morphine requirements or pain scores, do you think it brings it? Can you keep this on the screen, because this is quite helpful picture. Can we not move this away? Yeah, keep it there, and we will talk about it in a minute. Right. Do you think it reduces the pain requirement down to 0 pain score, or do you think it brings it down to 1 and 2?
Most of my patient in 24 hours post-operatively is 1/10.
Yeah. So it reduces the pain pretty significantly. Okay. Now, if you people, before we go into how we do it, how much volume we use and stuff like that, but if you people watch some videos on YouTube on erector spiny block, the concept behind this is that we are injecting local anesthetic, which somehow seeps into the thoracic paravertebral space. So essentially what we are trying to achieve by doing this block is we are not going near the pleura. We are not going close to the spinal cord. We are going to inject the local anesthetic in the erector spiny plane, which I will explain in a minute in further detail. But we are getting the pain relief, which you would get from a thoracic paravertebral block. Essentially, that is my understanding of this block. Now, if you guys look at the screen share and the picture, if I'm looking at it correctly, on the right side of the screen, you see the subcutaneous tissue, the trapezius, rhomboids, the erector spiny muscles, and the TP, which is the transverse process of the vertebra there. Okay, the way I do it is I put the probe paramedian in a longitudinal plane on just the right or left of the spinal cord, whichever side you want to block. Slide the probe out slightly laterally and angulate it medial to lateral. So as if you are looking from the medial side to the lateral side, and that angulation gives a very clear view of the transverse processes. And essentially, we are bringing, now if you look at the second picture on the right-hand side of the screen, and he's brought the needle into that plane, what I try to do is, instead of bringing the needle tip here, I bring the needle tip right onto the transverse process. So by that, I'm sure that I am hitting the point of my interest, and then inject local anesthetic. It is volume dependent block, depending on the patient's weight, how much local anesthetic you want to use. Do you want to do it unilaterally or bilaterally? I've done them bilaterally as well. They work very well for rib fractures, bilateral rib fractures. And you inject 30 to 40 ml of volume. And as I said, that volume ultimately seeps into the thoracic paravertebral space, because by the knowledge of anatomy, we know that in this plane, there are no nerves which run. There's no neural structures in this tissue plane. It has to go to the thoracic paravertebral space for it work. Sorry, I missed the question which appeared on the screen. Can we just go back? What was the question? Can you say it aloud, please? Hello?
Oh, sir, I suppose it's just a comment rather than a question.
And what was the comment?
Yes, we place erectospinal block catheters for post-op
Yeah.
pain in thoracic surgery by hitting
Yeah.
transverse, but for placement of catheter, little bit away from transverse.
Okay, okay. So I have put catheters in there. I think once you open up the tissue plane with local anesthetic, putting the catheter becomes easy. And at that point, it doesn't matter where your needle is. So wherever I am putting a catheter in peripheral nerve blocks, what I tend to do is I bring the needle tip into the tissue plane of which is the target plane, then open up that plane with local anesthetic, then put the catheter in, and then inject further local anesthetic from within the catheter to make sure that we are still in the right tissue plane. That is how I would do that. So 30 to 40 ml and I would do it at T67 level if I'm doing it for lap chole, which is just to block the subcostal, but no, the local anesthetic spreads in the thoracic paravertebral space, which is a continuous space from T1 down to T12 L1, and it blocks all the nerves which are in that plane, which essentially means that by one injection in the erectospinal plane on one side of the chest, we are going to block the pain on the ipsilateral side from subcostal down to the L1 level, which is the suprapubic level. So one point injection can essentially block the half of the abdomen on the side you've done the injection. Now, again, as I said, if you're interested in this, please go on YouTube, please watch the videos. I think the important thing to remember is where you can use it. You can use it for rib fractures, you can use it for abdominal surgery, you can use it for lap choles, open lap choles. I did one for open lap chole patient. 48 hours later, the surgeon came to me and said, I would like to tell you something. When the block wore off, patient had pain, and then he realized what magic you had done. That was literally the words of the surgeon to me. So depending on the volume, it will last up to 24 hours, but I have seen it last more than 24 hours. What is the experience within the group?
Sir, I will just share an experience, which is actually slightly what we say out of box, but actually in our circumstances where we don't have sometimes block needles, actually I have done a lot with 20 cc syringe, simple a single shot using the ultrasound probe, just touching the transverse process, withdrawing it and injecting it, and even this was quite effective. But of course, if you are using it with the TWE needle, you can pass the catheter, or if you are using it with the block needle, of course, that will be blunt tip and will be more safe.
Yeah, actually, basically, it's an epidural catheter. I think even if you don't have any other needles or catheter sets, just put an epidural catheter in there and it works. And when we use the catheter tips, the catheter kits, they are Tohi needles and they are epidural catheters. There's no difference.
Yes, of course. Sir, one more question, because the problem with this block practically is that we have to change the position, like we have to make it lateral to perform it. That's why, how will you compare this block with the quadratus lumborum block or subcostal
Rectus
nerve
sheath
block?
block. Yeah,
Yes,
yeah,
like
okay. So let me go back a few years in my experience. My area of interest was lower GI, and we were doing a lot of abdominal work, and we were doing a lot of tap blocks. Now, when I started doing tap blocks, some of them would work and some of them would not work. And obviously, one would analyze why they are working and why they are not working. And I learned a few tips, which I'm going to share with you. And I would like to hear from you as well. So basically, tap blocks work very well as long as you go posterior, as far posterior as you can, almost QL kind of area. Tap blocks essentially are very good blocks for phenosteel incisions, T12L1 pain. Tap blocks are not great for midline pain because the way the nerves branch out and the way the nerves line the rectus sheath, I don't think by doing a tap block we can cover that. QL is a different story, and I'll come to QL in a minute. So in my experience, you can do tap blocks at the angle of triangle of Petit, as traditionally it's been called. You can use the ultrasound, do it at that level, you'll get a very good T12L1 block. You can do a subcortical tap higher up for lap chole, open chole kind of incisions, which will be just under the rib margins. That also kind of works, but it's not very effective. QL block is a completely different block in the sense that QL is so far posteriorly that we are trying to catch the nerves as they're coming out of this spinal column, right? But again, please bear in mind, most of the anterior abdominal wall is innervated by the thoracic nerves, not by the abdominal nerves or lumbar nerves, right? So even if we do QL, the coverage to get T6 is challenging. I've never been able to get coverage for T6, but for lower T12, L1 kind of segments, you get a very good coverage with QL blocks. I have moved away from doing tap blocks, and I do QL blocks for cesarean sections and phenosteel incisions wherever I have to do them. If the patient is in supine position, have had the surgery, and it's a midline surgery, and you're worried about positioning them, I would simply do rectus sheath blocks for the anterior abdominal wall midline incision, right? Nothing works better than a rectus sheath block. Forget about QL blocks, forget about transversus abdominis plane blocks, rectus sheath blocks. Now, the rectus sheath blocks are also very interesting in the sense that you can do a single point injection and hope for local anesthetic to spread along the whole rectus sheath, which is just under the rib cage from xiphoid down to the pubic symphysis. But I tend to do 3-point injections or 2-point injections to get a better coverage on each side. Generous with volumes, you can use dilute solutions. I would inject 40 ml to 60 ml each side, depending on ropivacaine or 0.125% bupivacaine, whichever solution I'm using. I have done 60 plus 60 ml rectus sheath blocks with 0.1% ropivacaine, and they have lasted good 24 to 48 hours. Now, going back to positioning for the erector spiny plane blocks, if my surgeon tells me that it's high probability that lap chole will be converted to an open chole, I will sit the patient up, I will do the block, and then I will send them off to sleep. In the rib fracture patients, it becomes difficult. If they're unable to sit up because of other fractures, pain issues, I will lie them on the side and do them. And I have been able to do both sides of the patient while they're lying on their side. I'm talking about the erector spinae plane blocks. So yes, sometimes if it's an elective situation, you have to anticipate, you have to talk to the surgeon, talk to the patient, and do them preoperatively. Sometimes I can send the patient and I say, okay, if it converts into an open procedure, we'll do the block before we wake them up. And there have been times where operation is finished, patient is still asleep, I put them on their side, I do the block, I put them back on their back, and then wake them up. Any comments?
Yes, sir. Perfect. Sir, there is a question about the use of opioids.
Yes.
Can we use opioids as adjunct to prolong the block in case we don't use catheters?
Okay, opioids in the tissue, in the local anesthetic?
In this erector spinae block mixture.
You're talking about mixing opiates?
Yes.
Okay. In my limited experience of mixing opiates and literature search, I don't see any advantage of mixing opiates. I have got my own personal point of view of mixing dexamethasone, which I will share with you shortly. But in my experience, I don't see any advantage of mixing opiates in tissue plane blocks. Is there anybody in the group who've got a different experience than this? Please speak.
I commonly use 25 max fentanyl.
Okay, and do you think you get any added advantage of that if you had given that same 25 mics IV?
No, I have no experience for this regarding the comparison between the IV and mixing with the erector spinae block.
Okay, and that is my understanding. You put local anesthetic in there, it's the same as if you are giving IV in a way, because ultimately it is going to work by absorption into the bloodstream. It might take longer for it to get absorbed in the bloodstream, so you might get a slightly delayed action. But 25 micrograms or 50 micrograms in 40 mils of solution injected in a tissue plane, I don't think it's helpful. I don't think it's neither here nor there, as we call it. That is my personal experience, unless somebody in the group has got a different experience and would like to share with us.
Sir, regarding dexamethasone, because dexamethasone, even if you are giving IV or if you are using in that mixture, it prolongs the effect, am I right?
You're absolutely right, but I choose to mix it with local anesthetic, and I'll tell you why. Okay, now this is something which is based on my understanding. Nobody's researched it. I would like one of you guys, I'll come to clonidine adrenaline in a minute. I would like one of you guys to research it if you can, but I will share my hypothesis with you. Okay, whenever we do blocks, which are plexus blocks, let's talk about interscalene, let's talk about infraclavicular, supraclavicular blocks, we are very close to the nerves with the needle tip, which is different from a tissue plane block, because in tissue planes, we are not close to any nerve. Right. So when we are close to the nerves, there is a small chance of A, damaging the nerve with the needle tip, and B, causing damage to the nerves, especially if they are non-myelinated fibers in the interscalene area with the local anesthetic concentration. So as you guys know, transient neurologic syndrome, or TNS, has been described with lidocaine in spinals. And hence, we don't use lidocaine in spinals anymore, because we know that high concentration of lidocaine, 5% lidocaine, in the spinal space cause damage to the nerves. Okay, so that's one thing. So I am thinking about damage to the nerves by either the needle tip or the local anesthetic. And separately, I'm thinking about the anti-inflammatory effect of dexamethasone, which has to be preservative free. And we have been using it in nerve pain for decades in chronic pain. We know it is safe. We know it reduces inflammation. We know that no harm comes to the patient by injecting preservative-free dexamethasone near the nerve root. So in my head, if I mix it with the local anesthetic, when I'm doing an interscalene or supraclavicular or infraclavicular block, then it might have some protective effect against the nerve damage caused by the nerve, by the needle, or the local anesthetic. And even if it doesn't have that effect, there's no harm in it. It's going to prolong the duration of action as if you gave it IV. So if I was doing a block in a patient, I would always mix local anesthetic when I'm going near the nerves, not when I am injecting in the tissue planes. That is my thinking. I would like to hear from you people. What do you feel about it? Have you thought about that side of things? And if you have not, by hearing me say this today, do you think it makes sense or it doesn't make sense? The dose I mix is 5 milligrams of preservative-free dex in 20 mL of local anesthetic solution. I would like to hear from you guys. What do you think about the hypothesis I shared with you?
But if you hit the nerve with the needle, how well the dexamethasone would protect?
And we know that any injury causes an inflammatory reaction. And we know that dexamethasone is one of the strongest anti-inflammatories we know. That is my hypothesis. I don't have anything to prove or disprove it, but I can tell you one thing. I have not had, over the last 10, 15 years I've been using dexamethasone, I've not had a single case of neuropraxia. But I don't know whether it's my technique or it's the dex, because I've not done research. I'm just thinking in my head, even if it doesn't give any benefit, it does not cause any harm. That's the first thing, which is in my head. And the second thing is, if I cause some damage to the nerves, it might have some protective effect. That is what I'm thinking.
Sir, there is a problem with regarding the preservative, because some of the ampules which are available in majority part of the world not mentioned. So that's actually a problem, the tricky part. This is one thing. Okay. And another thing is that actually in my experience, whenever I've used it, sometimes the effect is so much prolonged that it actually creates a problem in a different way, that you are not expecting the block to prolong for, like, I have very terrible experience that even after 24 hours, the effect was still patient was having weakness. So like I correlated it with because there was nothing wrong other than that I had used dexamethasone in the solution. But your point is absolutely valid, because dexamethasone is just like you can say a magic medication, and nobody knows about its exact mechanism of action, because it's using in post-operative nausea, vomiting. We are giving it for like a sort of mild inflammatory response to the laryngoscopy and intubation. So there are so many things which even people claim that there is some opioid sparing effect because of the anti-inflammatory effect. So I think it is just like a Kalashnikov burst, that you will get something. There is no harm except for the problems which may occur relate in diabetic patients, slightly increase in blood sugar or things like that. Otherwise, dexamethasone single dose will have much benefits than any problems. Exactly. Other than the preservative only.
Exactly. Okay. Now coming to the duration of action of the block and prolongation by dexamethasone, I'll share my view on that. I think normally the block with dexamethasone should wear off within 24 hours. There are times when the block lasts longer than 24 hours, And I don't think it is dexamethasone which is causing this. In my view, it is intraperineural injection which causes this. I'm not talking of intraneural. I'm not talking of injecting inside the nerve. I'm talking of some local anesthetic going in the perineurium, which is the outermost sheet of a nerve or a nerve bundle. So there have been some studies where they looked at local anesthetic in the muscle around the brachial plexus versus the local anesthetic outside the bundle, the nerve bundle. Then they compared it with local anesthetic inside the nerve bundle, which we try to achieve. But then there is another level, which is called the perineurium. And accidentally, we might inject a small amount of local anesthetic in the perineurium. So I get from my surgeons once a month or once every 2 months, where they say, oh, your block lasted for 2 days or 3 days. I think the explanation I have for that is not dexamethasone, because if it was dexamethasone, all my blocks will last for 3 days because I always mix it. I think it is that we end up injecting something or a very small amount of local anesthetic in the perineurium, and that doesn't get absorbed away in the blood as quickly as the rest of the local anesthetic does, and it blocks it for a much longer duration of time. And to the best of my knowledge, it does not cause any nerve damage. There was a question about permanent nerve damage. I have not seen one in my 24 years of anesthetic practice. I have in my personal practice, but I've seen one with a landmark technique with interscalene block, which happened to one of my colleagues. There was one case of a permanent nerve damage, which, like, outside reading the books, I have seen only one. Now, have you guys seen any more than this?
We can just pray that we don't see before our death.
Yes, exactly. It's so rare. So what do you quote? Now, we always do informed consent. What incidence or what ratio do you quote to your patients about chances of a permanent nerve damage? Anybody in the group?
Actually, majority patients where we have any doubt or any risk, some people will avoid it just to avoid the double crush syndrome, like in a patient with that risk. So we are filtering those patients, and I think that's the only thing, because even because I have worked in Pakistan as well, so I know that in some limited resources, when we don't have the proper block needles, even people are using the spinal needles which have cutting edges, and even then those there are not much incidence of nerve injury, despite the fact that it can, because it's
Now I slightly worry about Pakistan in the sense that we don't have a follow-up system.
Yes, you're right.
Yeah, so we might be causing some injury, but we might never hear of. But at least in the UK and Canada, if I or one of my colleagues did a block and there was a problem, we will hear, because the patient will come back, there will be a follow-up. So that's one thing. Now, somebody in the group said 1 in 100,000. There was a document from the Royal College of Anesthetists or AAGBI, one of those. I think it was AAGBI, and which quoted the incidence of permanent nerve injury between 1 in 6,000 to 1 in 30,000. It might be even more rarer than that, but that is what I quote to my patients. And as far as I remember, this was without ultrasound. So now that we use ultrasound, it should be less than that. But if you read studies, the studies show the chances of neuropyrexia are not any different with or without ultrasound. And I'm going to share another thing with you, which is very interesting, comparing with ultrasound to without ultrasound. Without the ultrasound, when we were doing the blocks, as soon as we get the twitch, we will keep the needle there and inject the local anesthetic. Yeah, okay. But with the ultrasound, what we are doing, we're putting the needle in, we can see where it is, we inject a little bit. Oh, it's not going around that route. Take the needle out, angulate it further down, inject a little bit more. So actually, we are doing more needling without the ultrasound compared to, with the ultrasound, compared to when we are not using the ultrasound. Because when we are not using the ultrasound, we will not move the needle once we got the twitch. But now I'm doing a block. I at least go in 3 or 4 different quadrants to inject local anesthetic and make sure all nerve roots or branches, whatever my target are floating in the local anesthetic. The consequence of that is I am doing more needling. What do you think about that?
I absolutely agree to your point. Rather, that's why in some scenarios, if I don't have any risk with the of phrenic nerve involvement, I prefer to give supraclavicular rather than axillary, because in axillary again you have to go 2-3 places. Of course, the axillary will be much safe, but in that regard. But if you go to the near the between the bone and the artery, that place, actually with single place there are most chances that it will spread. So your point is absolutely valid. I think most of the people now, with when they become relaxed, actually they are playing with the needle. When they are able to see the needle under the ultrasound, actually that is the time where they can create more problems as well, because of your effect.
Exactly.
And I will say one more small point, that in my opinion, where we should just try to encourage using smaller syringes rather than big, like 20 cc we use practically, because we are lazy to use 3 syringes of 10 cc or 2 syringes of 10 cc. Because if you are using a bigger syringe like 20 cc, there will be unintentionally creating more pressure.
Sorry, I must differ from you here.
Okay.
And you can correct me if I'm wrong. With 20 cc, you create less pressure. With pressure is force per unit area. As the plunger of the 20 cc syringe is bigger, you will create less pressure. With the 2 cc syringe, you'll create more pressure. It's force per unit area.
I think with 20
cc, you can even try that. You can connect a 20 cc syringe to a balloon, whichever way you want to test it, you can test it. But I'm pretty certain about this. It's force per unit area, and you create more pressure with a 2 cc syringe.
If you may allow me,
I give you example of that. You will find out. Take a 25 gauge needle, put it in front of a 20 cc syringe, and inject the solution out, and then use the same 25 gauge needle, put in front of a 2 cc syringe and inject the solution out. You will see it is easier to inject with a 2 cc syringe, because you can create more pressure.
No, actually, sir, I think I will rephrase. Maybe I'm trying to say that we should use a smaller gauge needle, because
needle or syringe?
I'm sorry.
Syringe.
Sorry,
Needle?
I'm sorry. Syringe.
Yeah, okay.
A smaller syringe, that for the same reason. Maybe I said in other way, but my purpose is that the same, that when we are giving with the smaller needle, there will be less chances of injury. Am I right?
I don't think so. I would. I think the thing is, some places the anesthetists themselves inject. Sometimes I inject myself when I'm close to the nerves. I don't trust my assistant to tell me it's hard to inject or not, right? So you got the needle in place, you got the probe in one hand, and then you can inject yourself. I know of some hospitals in the UK where that is the routine practice. I don't think it will make a difference. I think what makes a difference is whatever you use it consistently. So you know what is the normal, your muscle memory would know what is the normal pressure. If you keep changing the syringes, you are creating different pressures with the same amount of force. As you, then your muscle memory will not be able to tell you that this is too high or it is normal. So for example, I use 20 ml syringe every time. I use the same gauge of needle every time. My muscle memory will tell me this is normal or this is high.
Are you using the pressure gauge?
No, we are not using the pressure gauge, but I'm aware they are available.
Yes. And another thing is that the same point which you told, that the person
Yeah.
who is injecting is very important, because if he
Exactly.
is using a lot of pressure, that can create a problem. And
Exactly.
actually the landmark, then ultrasound confirming with the nerve stimulator, and then pressure. These are four things which we can use to avoid nerve injuries, but there is no perfect match. Am I right?
Exactly. So I don't use nerve stimulator anymore. I just use the ultrasound, and when I'm doing interscalene or anything, I will inject myself. I'm in the tissue plane, like a tap block or like a PEC1 or a PEC2 or erector spinae. It doesn't matter. Anybody can inject. A monkey can inject. So
Yes.
that's my take on that. Uh, any other questions on erector spinae before we move on? And in that, we have covered a lot of things, actually. I think the discussion did not stay at erector spinae, but I would like to hear from people. Any comments on what we have said and was discussed before we move on to next question? We'd like people to talk to us. If you can, please talk to us. We'd like to hear your voice.
Yes, I have one point.
Sure.
Your
Can you
sound.
speak a bit
I
louder?
understand you mentioned, yeah, you mentioned that you like to inject yourself. Uh, how you manage doing injection by yourself, keeping in mind you have to manage the probe as well, the needle. So how you
Yes,
inject yourself?
actually, I will rephrase his question. I think
Yeah.
he's saying that how will you manage when you are you are holding the probe and you want to inject by yourself?
Okay. Uh, in my little experience, once the needle tip is where it is, you can let the needle go and it doesn't fall out unless you pull on it. So because we are using, all of us are using a little tubing which is connected to the needle. We are never directly connecting the syringe to the needle. There is no weight on the needle. So if I want to inject myself, and sometimes my ODP or assistant is injecting, and I want to be sure, I say, can I have a little feel, please? So I let the needle go, I inject a little bit, and I say, okay, the feel is right, you can inject the rest. So in my experience, whenever I do it, I can let the needle just go. I hold the probe with one hand, syringe with the other hand. It is connected to the needle through a tubing, so there is no drag on it. There's no pull on it, and needle tip stays where it has to stay. It doesn't move. You can try it. Even if it sounds implausible, you can try it next time you do a block, as long as your syringe is not directly connected to the needle.
Yeah, I think if you are visualizing the needle in the ultrasound, if it moves, you will know. So I think
Yeah. So probe has to be in your hand. You need to be able to see where you're injecting, right? And that's it. The other thing which goes without saying, but I'm just reiterating the point. If you're injecting and you cannot see the injected, stop. Just simply stop, right? That don't even assume that maybe your probe has moved or your needle tip has moved, because that is one thing that you might be intravascular. If you cannot see the smallest amount of injected, just stop. Try to see where your needle tip is, move the needle, do whatever you want to do. Don't assume that your probe has moved and now you cannot see where the local anesthetic is going. Right. Any other question?
I
Yeah,
have one
sure.
question. Can we use depomedrol or triamcinolone for apart from dexamethasone mixed with local anesthetic for a prolonged action, particularly thoracic neuralgia? If a patient is feeling mid-thoracic pain and we are going to block B6, D7 around, and we use triamcinolone or depomedrol mixed with local anesthetic.
Okay, so my take on that is, number one, in the acute pain world, I have never used it. I do some chronic pain. I'm not an expert on chronic pain. I do some chronic pain. And my understanding is that above L1, you are not recommended to use particulate steroids. The reason for that is that if there is an accidental intravascular, especially intraarterial injection of a particulate local anesthetic, it clumps, it occludes the vessel, and it causes spinal cord ischemia. So the guidelines from all the chronic pain societies I'm aware of is above L1, you will use non-particulate local anesthetic, which is dexamethasone, and below L1, you can possibly use, or you are allowed to use particulate local anesthetics, which is triamcinolone or methylpred. Any comments on this from the rest of the group? Any comments?
I will ask a question which is not related to erector spiny block, but actually this question was asked to me today by a first-year resident, and actually I was really happy to listen the question, and like I just want to confirm my answer. The question was, it's a very valid question actually. The question was that you are giving a epidural for labor analgesia, okay? And like if there is any possibility of development of epidural hematoma, okay, of course it's a rare phenomenon. Apparently you will not find any reason, but his question was that if you want to differentiate or you want to pick the development of epidural hematoma, because at that time patient will be receiving a local anesthetic and patient will be numb and maybe some heaviness if you have given a little slightly higher concentrated dose, more than 0.1%. So his question was that how can we pick if it happens? Because if it happens, for example, and you are picking it late till the time you are stopping the epidural medication and then it develops. So like his question was that rationale of diagnosis of epidural hematoma is early identification and going for any intervention. So his question was that how can we differentiate? Sir, your voice is not coming. We cannot hear you. Sir, you are mute. Unfortunately,
Okay.
Yes.
Can you hear me now?
Yes.
Okay. So that's a very interesting question. I've never thought of that, but common sense or previous knowledge will tell us that if there is a hematoma, you might get disproportionate block from what you expect. And then you will have to differentiate it from a subdural block, and also pain, because blood around the nerve roots will irritate that and might cause pain.
Pain as well as paresthesia. What about paresthesia?
Paresthesia, we are using dilute amounts of local, which gives them paresthesia anyway. So we tell them paresthesia is one of the signs that our epidural is in the right space.
And what about local pain? Local pain.
Localized pain in the back, number one, and disproportionate block out of expectation. These are the two things which come to my mind. Anybody else in the group would like to share?
Dr. Kamran, you will also appreciate that this question I really enjoyed, because actually I had to think a lot to answer, and it was asked by a first-year resident. So I was really happy that he has twisted my mind to answer it properly. Actually,
Exactly. No, that's impressive. That's impressive. But any comments from within the group?
So there are many people, many big names are here, but Dr. Tariq Bashir, I would like to listen from you. You are just silent. Yes,
Can we be differentiated from the mass effect, that if there is hematoma there, so there is pressure effect on the roots, and there may be a motor element also there. If there is hematoma, there are chances of hematoma there, isn't it?
Yeah. So again, going back to the same point, disproportionate block, what you're not expecting.
So,
but then we have to differentiate from a subdural block, which happens sometimes. Never happened to me, but allegedly you get funny, patchy block with subdural catheters. Anybody has experience of dealing with a subdural catheter? Can you share what do you see or what do you find?
sir, I have never seen. I have never seen.
Yeah.
We have one incidence in my chronic pain management program for a transformational block. It's a subdural, and a small amount of dye is spread all along the vertebral column. I seen in the fluoro. So
Right.
just repeat the procedure. So
Yes.
in the plane, only small volume can give you a very high block.
Exactly. Exactly. So yeah. So now if you put it in the context of the question which was asked, that will be one thing which we will need to differentiate from, whether it is a subdural catheter or a hematoma causing that disproportionate block. But I think high index of suspicion is one thing we need to always worry about. What has happened in my experience with epidural catheters, if somebody is getting a disproportionate block, especially post-operatively, I tell them, stop the infusion, let the block recede, and then we will restart the infusion. And the most of the time, it works that way. But if you have stopped the infusion and it's been 4-6 hours and still a dense block is there, I would take them to CT or MRI. Great. Now, I cannot, because you're sharing the screen, I cannot see the comments. In the comments, many people have asked questions or given comments. Can we go and see them and try to answer those, please?
What about mixing short acting and long acting local anesthetic? And
Yeah, I always do that. Whenever I'm doing a block for an operative procedure, I always do that.
what about the one?
If I'm doing a block for post-op pain relief and patient is getting a general, then I only use the long acting. We cannot hear you. It's very, very dim.
Yes, actually, Dr. Kamran, I think the only danger is that some people don't have the junior residents, they can do this mistake that they have to reduce the dose accordingly if they are using two.
Yeah.
Because
so the formula I use is very simple. Divide the patient's weight into half. Right? For one half, use the safe dose of lidocaine. For other half, use the safe dose of ropivacaine, levobupivacaine, bupivacaine, whatever you want to use. Just very simple. Divide the patient's weight into half. If it's 80 kg person, think it's a 40 kg person. Give a safe dose of lidocaine for 40 kg, mix it with a safe dose of bupivacaine for 40 kg. That's what I do. Any comments on that? Good. Dr. Zishan, can you go back to the comments? Let's see what comments and questions have been in there.
yes,
can
sir,
you screen share those?
I think you have answered majority of the This is from the start.
Okay.
Erector spiny block in thoracic surgery, and then about dexmedetomidine. Yes, dexmedetomidine. Yes, this is
Okay. Right.
use of
So,
dexmedetomidine.
okay, now my limited experience of dexmedetomidine is I've never used it with the local anesthetic, but I am more and more using 5 micrograms in spinal. It causes disproportionate hypotension, so you need to have phenylephrine or metaraminol running, but it extends analgesic effect. Sorry?
I'm sorry, I think his mic is on. I'm sorry. Yes,
Yeah.
yes, Kamran.
Yeah.
Yes, you're
So
right. Dexmedetomidine will cause more hypotension and bradycardia even.
I've not seen bradycardia with spinal.
Okay, because I have never used it in spinal.
Yeah.
But
so I'm using, I recently, just yesterday, used 5 micrograms of dexmedetomidine with 3 ml of 2.5% plain bupivacaine. Because the patient was going to get a general anesthetic and an open laparotomy, we did that. We surgeon infiltrated local anesthetic in the midline. 4 hours of operative time, patient woke up with 0 pain. There was no motor blockade. The combination of midline infiltration by surgeon and 5 micrograms of dexmedetomidine, 4 hours of laparotomy, patient wakes up with 0 pain. I have also used it in a proper spinal, like for a knee procedure. The motor block lasted for 6 hours with 5 micrograms of dexmedetomidine. That is some impressive time. I used 15 milligrams of heavy marcaine, which is 2 ml of 0.75, which we have in Canada, or in the UK, it will be 3 ml of 0.5 heavy marcaine. I put 5 micrograms of dexmedetomidine, slightly more hypotension than expected, but you can counter that. No bradycardia, 6 hours of motor blockade. It might be undesirable in certain circumstances. It might be desirable in other circumstances.
Yes, one more point to clarify, and that, for example, because in my point of view, if you are using dexmedetomidine, I have never used, but intrathecal morphine, because theoretically it's just like not absorbed and it will remain circulated and it will have prolonged effect. What about use of fentanyl? Because fentanyl is highly lipid soluble, so it will not stay even in intrathecal for as long time. So if you are using any intrathecal opioids, so what do you think? Is there any advantage of giving fentanyl as compared to morphine if you have available both of them?
Yes, there is definite advantage. It improves the quality of the block.
No, a comparison between fentanyl versus morphine.
Okay, let's talk about 3 or 4 different scenarios. Let's talk about no fentanyl, plain spinal, and a spinal with fentanyl. First of all, it improves the quality of the block profoundly. And I am talking about by personal experience, where especially in cesarean sections, some of the surgeons bring the uterus out of the abdominal cavity and stitch it. If you're not using fentanyl, patient feels discomfort and pain far more if you have used fentanyl. So that's number one. Now we are talking about fentanyl compared to morphine. When you mix fentanyl with local anesthetic, you don't get any prolongation of action. When you give morphine with local anesthetic, you can have prolongation of action. And we are talking about preservative-free epidural, or what we call it epimorph in Canada. You get duration and you can get added analgesia up to 16 hours later. But the chances of respiratory depression, delayed respiratory depression are there. Now, if you're not mixing fentanyl with that epimorphine, you don't get that quality of block improvement just with morphine. So in cesarean sections, our routine in my current hospital is 15 mics of fentanyl, 100 mics of epimorph plus local anesthetic. So we are mixing 3 drugs for cesarean section.
And how much local anesthetic you are giving them?
It
Are you
depends on
reducing-
everybody, anywhere between 1.2 to 1.45. I am towards the higher side. I'm using 1.45 of 0.75, not
Oh.
0.5.
Like you are giving
Right.
around 12 milligram or 11
Yeah,
milligram?
about 10, 12 milligrams, right? Okay. The reason I'm doing that, can I share avoidance of subject? Okay. The reason I'm sorry, I couldn't understand what was that. Hello? Hello? Can you guys hear me?
Yes, we can hear you.
Yeah, okay.
Yeah.
Driving at this stage, but we see more rain across the south.
I think somebody is unmuted and we are getting a weather statement from them. Okay, so in terms of mixing fentanyl with epimorphine, we are getting the added advantage of good quality of block there and then, prolonged analgesia. I will not do that with diamorphine because in the UK we have got diamorphine. You put diamorphine in, you get immediate effect, you get prolonged effect. So there's no need for that. But in countries where diamorphine is not available, I would mix fentanyl and epimorphine together to get that immediate effect and the prolonged effect. It's just like mixing lidocaine with bupivacaine. Does it answer the question?
Yes, sir. Same here. We are using in some patients 0.5% bupivacaine with fentanyl and morphine.
Yes. And for what procedures?
Sir, elective cesareans, and recently I have used in last 2 patients, and it was very effective.
Yes. As somebody said in the comment, the chances of delayed respiratory depression are there. In the hospitals where this is a practice, the nurses will do hourly observations on them for first 24 hours. So we will not send a patient to a ward where the ward nurses are not trained to look after epimorphine. So there are certain wards where the nurses are trained, then you'll make sure the patient is going to the right place with epimorphine. You would not send them to an unmonitored ward. Somebody asked a question about basalt gelish reflex. Can you speak up and explain what the question was, please? Hello? Hello, hello. I think they asked the question and they went away. Any other questions?
I think maybe this question may be related to happening of the hemodynamic changes while after giving subarachnoid block. I suppose.
I've not seen basalt gelish reflex except in a beach chair position or a sitting up position for, not a beach chair position, sorry, sitting up position for shoulder surgery. Okay. So I've not seen it anywhere else. Has anybody else seen it somewhere else? No? Okay. Now there was a question about mixing preservative-free tramadol and bupivacaine. I've got zero experience of that. Can anybody share their experience on that? I've never put tramadol in anything. I don't believe in that drug.
Actually, tramadol, people back in Pakistan, they are using it in epidural. They are using it in
Is it
epidurals.
preservative free?
I think I have never used it. Actually, I'm not a big fan of adding opioids in local anesthetic in central axial or epidural.
Okay. Yeah. Right. So you're still on screen share. Can you please stop the screen share so we can see any other questions or comments?
Yes, I think, sir, there is no further question. So
okay. So where do you practice? Where you say it's routine practice with spinal?
Pakistan.
Pakistan. Okay. How much do you put in? And is that preservative free?
Avais, it is better if you speak out, please. Don't hesitate. We are a little loud. We cannot hear you.
Yeah.
Yes, sir. We use it 10 to 20 mg with 2 cc of heavy bupivacaine, 15 mg. But I don't know that we get any added benefit out of it, like prolongation and analgesia, because as you said, we do not follow our patient. But routinely we use it preservative.
Okay. So it has the preservative. Is that right?
Actually, Dr. Kamran, the problem is that majority of people, they don't claim about it. So maybe Dr. Tariq Bashir will say that there is a gray area, that if the manufacturer is not claiming and that it's purely safe to be used in spinal, I don't know whether you should use it or not. Yes, Dr. Tariq, please. Tariq bhai, you can ask.
We have never used it. Back in Pakistan, we never used it for spinal, but definitely we used in epidural trauma. But the issue was that the company claimed that it was preservative free. But whenever we asked them that write down for us, they never wrote down for us. So we have to quit that. But definitely it had a good effect. It has some beneficial effect. As you know that we have no morphine available free back in Pakistan. So we used to add it, and it has definite effect to prolong the analgesic effect of the epidural. But our company verbally used to said us that it is preservative free, but they never wrote down it for us.
Okay, yeah. Now, my understanding would be that in the package insert, it will say what preservative it has. And if it doesn't say, then that means it has no preservative. It might not say preservative free, but when you talk about the ingredients, it says sodium citrate or whatever they use. And my understanding also was, and this is from the days I was practicing in Pakistan, that certain preservatives are considered safer than the other ones. I can't remember which ones were considered safer than the other ones, but that was also a thing in Pakistan at that time, that, okay, this preservative is okay, but we shouldn't be using the other one. So I don't know the right or wrong answer to that. There were two questions here. One was from Amjad Mahmood. What level would you give spinal for laparotomy? Normal level, L3, 4, L2, 3, obviously. And there was a question by Avais Durrani, dexmedetomidine, will it spread where the local spreads or its spread will be beyond? I think it's very difficult to say. I think it will spread according to its own pharmacokinetic and dynamic and chemical properties, and the local anesthetic will spread according to its own physicochemical, specific gravity, and pharmacokinetic properties. That's what I would say. Right. Okay, any other questions?
So I have a question. Do you use...
I have a question as well.
Sure.
Okay, so I'll start. Assalamu alaikum, I'm Mariam. I'm really honored to be here and to be a part of this. So I had a question. So I'm currently doing residency from Aga Khan. So we don't use lignocaine with bupivacaine. So what we do is that we only use bupivacaine, or we've used fentanyl in the past when we had it. nothing else. So how about mixing lignocaine, like the 2% xylocaine that we have, with bupivacaine? What is your experience regarding that?
I think it simply increases the speed of onset of the block. So my practice is for all neck of femur fractures, I do fascia iliaca block first, and the patient is awake. That's the only block I do when the patient is awake. Otherwise, all blocks are patient asleep. We can discuss that if you want to. Why not? So I do that, and I mix lignocaine with bupivacaine. Within 5 minutes, I position them with the broken side down. And this is a very interesting concept. I will ask people a question in a minute. I position them broken side down. I do the spinal, and I use heavy marcaine. I take my time to inject heavy marcaine, smaller amounts, especially in frail elderly patients, and try to get a unilateral block with the spinal. So adding lidocaine, I think, definitely improves or increases the onset time. Any further? Did I manage to answer your question?
Yes, sir, you did. So what about the volume? Then does the total volume that you're giving the patient, does it change?
As I said earlier on, take patient's weight, divide into the half, right? Half you will give lignocaine safe dose, half you will give bupivacaine safe dose, and then you decide on the volume. So normally for unilateral blocks, you got enough volume. Fascia iliaca block, you take 30 mils maximum. So 15 mils of 2% lignocaine with adrenaline is within safe limits. 15 mils of 0.5% bupivacaine is also within safe limits for a 70 kg adult.
Thank you, sir.
Yeah. Okay. So my question is for broken femurs, neck of femur fractures, would you position the patient broken side down or broken side up? And why? That is my question.
Broken side down with a heavy marcaine might give a femoral block to reduce the pain, and broken side up can be done with a plain marcaine.
No, but I'm talking about in terms of pain and discomfort to the patient.
Yeah, if a femoral block is applied earlier, then it will reduce the pain there and then.
Okay, so let me ask the question differently. Let us assume that we have not given patient any pain relief. We are really cruel people, and we have to decide between broken side up or broken side down, which will be more painful.
Broken side down, of course.
Okay. Anybody else in the group? Any comments?
Yes, sir. Broken side down will be more painful.
Broken side down, that's what we've observed.
More painful? Okay. Anybody else in the group?
I think broken side down would be less painful.
Exactly.
It's because the mobilization that it requires for the broken limb to be moved up. Sorry, I did not introduce myself. My name is Dr. Adil. I'm a trainee in Pakistan. Yeah. So I think broken side up is like more mobilization, more pain. So broken side down is less mobilization.
Exactly. So my understanding of basic principles of fracture management is you immobilize the fracture. That is why you put casts. That is why you put traction on patient. So if you have left the broken side up, the leg is flailing in the air. It's not supported by anything. It's constantly moving. Broken side down is you've put the patient on there and you have immobilized the fracture. And now you can use the leg up to bend a little bit more to give you a better position for doing the spinal as well. So I am 100% convinced from my experience and everything that broken side down is less painful. Now, I would like you guys to go back and think about it and try it. And if we ever meet some other day virtually, just let me know what your experience tells you.
Sir,
And
I'm sorry, I'm just, there will be another advantage that you are making it unilateral. So if you can keep the patient in that position for some minutes, and it will actually increase effect on that side as well.
Yes, exactly. But somebody in the group said you can use the isobaric or hypobaric marking to achieve the opposite. It's not as effective and sure shot as compared to the heavy with the broken down. So I met a guy from Italy who would say, I can bet I can get unilateral blocks. And everybody else said, we never get them. And he said, yeah, because you don't have enough patience. I take 7 minutes to inject 3 mLs or 2 mLs of local anesthetic in the spinal for a unilateral block, drop by drop by drop by drop. And you will actually get a unilateral block. So I am very impatient. I cannot wait 7 minutes, but I try to take about 2 to 3 minutes to inject that. And I get, yeah.
Yes, actually for that you can, like, for example, if you are, because even unilateral block is the thing which people are not using it as much as they should, especially in like TKRs or any procedure of one side, you will get a prolonged effect and you will have less hemodynamic instability, if I'm wrong.
Exactly. And that is the only time I will take longer than 3 minutes if I want absolute hemodynamic stability, patient with aortic stenosis, which is not critical, or severe moderate aortic stenosis, where we know that we are doing a spinal and we don't want hemodynamic instability. I will take up to 5 minutes to inject. We get reliable unilateral blocks with that, but you have to take your time.
Yes, sir. Actually, Dr. Bilal Suhail were asking a question, and then we will take the last question of Dr. Adil. Dr. Bilal, I'm sorry, you were asking some question when you were interrupted. Yes, please, if you can. Yes.
Thank you. I just want to ask Dr. Kamran whether you use ultrasound guided spinal anesthesia routinely, or you use it for difficult cases.
I only use it for difficult cases. I don't use it in real time. I will just mark the midline, mark where the spinous processes are with a marker pen. I don't prep the probe. I do the ultrasound before, do the marking, then prep the skin and do the spinal. And most of the time it works. I think the key here is if you found the midline, you'll get the spinal.
Yes, I will just add on to it that you can measure the level of the vertebra you are targeting. You can measure the distance from the skin to the space, and of course, where is the midline? Okay, so that will, because there is no advantage of doing it real time. There is no advantage. So So yes, Dr. Adil, can you ask your question and then we will finish?
Yeah.
And
I did not have any specific questions. I just wanted to add into a point. As Dr. Kamran said, that the guy from the Italy said if you inject it very slowly and then you can achieve unilateral block. I read it somewhere that is because that when you inject too fast, like within a few seconds or even a minute, then there is a turbulent flow that generates inside, and the heavy bupivacaine does not get time to settle, and it spreads to the nerves that are to the opposite side as well. So the real thing is, for a hyperbaric solution, it should be injected really slow to get it to settle down easily on that side.
Yeah, 100%. But you and me are saying the same thing.
Yeah, Dr. Kamran, but my point of view is that if you are doing it in sitting position, how will you do? What will be the advantage?
You don't. You decide what you want to achieve. You want to achieve a unilateral block, you put them on the side. You want to do a saddle block, you sit them up. You want to do a perianal block,
because
I will share one last thing with you, which I've done some research myself on, presented in few conferences as well, is the spinal perianal block. It is lower than a saddle block. You sit them up and you inject about 0.7 mils of 0.5% heavy marcaine, sit them up for 5 minutes. You will just get S345 block That's enough for hemorrhoid surgery, perianal surgery. Actually, I have just achieved as 4 or 5 blocks, and people can still move their ankles, have the surgery done. They can actually walk straight away after the surgery.
But the only problem is that if it is in lithotomy position and the patient is moving the limbs, does it create any problem to the surgeon?
Not really, because you talk to the patient, you explain to the patient, you tell them what is going to happen, why you are doing that. They will go home quicker. They will have no leg weakness. Their legs will be put in lithotomy. So it's all to do with the patient education as well.
Yes. Yes. Dr. Tariq Bashir, you were asking some question? Tariq bhai, you want to ask any question? I saw your hand raised.
Yeah, sorry. My personal opinion was that when we get a unilateral block, the issue is that patients start feeling pain in the normal leg after some time, and he starts moving with that. So how we come over that? So it is not better we give bilateral block and have some infusion of the phenylephrine or metaraminol other than we give a unilateral block.
Okay, I think you're absolutely right in what you say. Your point is valid, especially when they're in traction table. The other leg is at a very funny angle in a lithotomy pole. So you would like to have blocked the other leg as well. Point taken. There could be other procedures. For example, Austin Moore or hemiarthroplasty when the patient is on their side and the other leg's position doesn't matter. So you can use there. And also, we don't need to do it in everybody who's having the hip surgery done. We are talking about a small subset of patients where we really want to minimize hemodynamic instability. We are talking about moderate to severe aortic stenosis. We are talking about severe cardiomyopathies. We are talking about where you really want to have minimal hemodynamic effects, and that is where you will on balance decide to do one compared to the other.
I have one question regarding
Sure.
your unilateral. Do you reduce the dose of the spinal or use the
Yeah,
same?
I'm sorry,
Yeah.
I was mute. I was mute. Actually, I will just ask one question before we finish, which is not related particularly to this discussion, because like if I think Adil, if you have the same question, because how to establish yourself as an anesthetist in Canada?
Hello, sir. Hello, how are you? I'm Adil here. I'm currently residing in Milton, Ontario, and I've been preparing for my Part 2 examination for FCPS. So I'm going to be appearing in soon next month, hopefully, for my Part 2 examination. And after that, I plan to live here in Canada as I'm already here. I'm an PR here. So I just wanted to know what are the prospects and how can I go forward for residing rest of my life as an anesthetist in Canada if there is a possible way.
Okay, right. That's $1 million question, my friend. The answer to that is it is very, very, very difficult. My current understanding is there are 2 ways of doing it. One is you do MCQEE, then you will get an LMCC. Then you have to get in a training program as an international medical graduate, which will be next to impossible. I'm not trying to discourage anybody who wants to come to Canada, but that's the reality on ground. The other way of doing it is you can get an academic fellowship position in some university, but that is generally offered to people who come from Middle East and who bring their funding with them. There are some fellowships which are available, which are funded, but again, very competitive. You will get an academic license, and then you will be given time to, I think you will still have to do the training to do the Royal College of Canada exams and get into the system. Again, I think it's very difficult, but that's another way of doing it. There is the third way through which I came, but that is also becoming more and more difficult. My British training was recognized by Canada. The college recognized my CCT, and I got a license to practice in Canada, but they are making it also very difficult now. they will be asking to do at least MCQE exam, which is equivalent to USMLE or a PLAB exam.
And
So,
I'm sorry,
yeah.
sir, sorry to interrupt you. The people who have done USMLE or who have done some fellowship from America, are they having any chance to enter in Canadian system?
If you have done USMLE, Ontario might recognize you equivalent to LMCC. Again, getting into the training system will be very difficult. But if you have done your complete residency from USA, it will be easier to come.
Well, what about fellowship? Only the
not just the fellowship. I think if you live in Milton, Ontario, I would recommend, and you want to live the rest of your life in Canada, I would recommend you go to USA, complete the residency program there, come back.
Yes.
That's the easiest way.
So, sir, I'm really, really thankful to you to give your precious time.
Yeah.
And I will
I
suggest.
can add a little.
Yes.
Sorry to disturb. I can add a little. That one of my colleague who did his fellowship from the Aga Khan, the most prestigious university in Pakistan, he went to the Canada, waited for the job for 6 years. And now she is with me in UK to do the residency. And to just clarify the things that she has came from the Canada here to do the residency in the UK so that she can manage to get a job in Canada. So really, as Dr. Kamran has said, it is very much difficult to get a job in Canada.
So, sir, you're really a proud figure for us, because one of my childhood friend used to say that if you want the person from where I get the meat, he is a radiologist.
Okay, right.
Anyway, sir, thanks a lot for your time. And sir, actually, this I hope that you will share this experience to the other colleagues, so that they also give some time, because I'm doing it at my capacity frequently. Okay. But of course, the share of ideas and the extra senior touch will definitely help. Okay. And the people in Pakistan, there are two kind of people: the people who are not getting any advice, and there are people who are not interested in listening to advice. So I'm just facing a problem with both of them, but I'm trying my best. And if people like you help me out by giving some time, even once a month or twice a month, every other month, it will be a great help for all of the people who are listening. So thanks a lot again, sir.
Yeah, thank you very much. And thanks for having me, and have a good evening.